Hello and welcome to the Vestibular Disorders Association's video education event. Today's educational event is brought to you by the National Society of Health Coaches, providers of evidence-based health coaching and training and certification for more than 7,000 licensed healthcare providers. At the Vestibular Disorders Association, your story matters. If you are a vestibular warrior, we see you and we hear you, and we know that your journey back to balance has been a tough one, especially when it comes to navigating the healthcare system. When are you going to ask me about me? Has this ever been your silent scream during a clinic visit? This feeling hardly leaves you enthusiastic about following their recommendations and may leave you feeling misunderstood and frustrated, lost, or hopeless. Fortunately, many healthcare providers are adding certified health coach to their credentials through a program teaching licensed professionals how to alter their traditional patient engagement approach, really how we talk to people through evidence-based conversation strategies. I've done this and it's been revolutionary in my communication with patients and in my outcome. And in this live event, we're going to be joined by Melinda Huffman, or we are joined by Melinda Huffman, who joins us to educate vestibular warriors and those that care for them about health coaches.
Thank you so much, Kathleen and Danielle, too. It's so nice to be with you all. This is a very special occasion for me, so thank you.
We are so lucky to have you here. And if you don't mind, I would love to give our listeners and our viewers a little bit of your background, if that's okay. Yes. All right. So this is Melinda Huffman. She is a co-founder of the National Society of Health Coaches. She's a writer and a best-selling author. She is a former director of disease management for Amedisys, director of nursing education, Motlow College, and assistant patient care administrator for the Southern Tennessee Medical Center. Melinda has a BSN from the University of Alabama, Birmingham, and an MSN in cardiovascular clinical nurse specialization from the Catholic University of America in Washington, D.C. She is the co-developer of the first and only clinical model of evidence-based health coaching and is the co-founder of NSHC that provides health coaching certification, education, and training to clinicians. Welcome, welcome, welcome. Thank you so much for being here.
Thank you so much. I want to say again how much I appreciate the invitation. It's great to be with you all and to have learned more about VITA. I've been very impressed with everything that I've seen, and I've done more investigation about that, and it's just amazing. And I'm so thankful that there is an association that you all have developed and have organized and have led for people with vestibular disorders. I think it's wonderful.
Well, thank you. First, we kind of want to dig in. We want to know, what is your background? How did your nursing career lead you into this area of health coaching?
Well, that is very interesting. I had cardiac surgery as a child. And so that kind of set and paved the way. I can remember those details, even though I was 7 years old. I can remember amazing details about all of that event, quite amazingly, and even aftercare, catheterization, I mean, the whole 9 yards. So that really kind of set the stage for me to go into nursing. And then because of the cardiac history, to go into cardiovascular nurse clinical specialization.
So what did you find, or did you find anything missing in that experience with healthcare providers that led you to think that maybe the way we talk to people could be improved and patients could be heard?
Well, that actually happened a little bit later. I was caring for a caseload of cardiac patients, actually, and it just felt natural to me in so doing that I was able to converse with them in a way that really drew them into the conversation. My training had basically been, we're the experts. The patient is the receptacle, so to speak. And we've learned all of these clinical interventions that if you do the things we tell you to do, then you will achieve this outcome, hopefully. Now, we know there's other, ramifications, other reasons why those outcomes might not be met. But of course, all of us as clinicians have been trained to impart those most favorable interventions that would yield a best outcome. But there was something missing in all of that. I was doing all of the talking, and the patient, like I said, was more of a receptacle. So I really began to engage them in a different way. It didn't have really The science was there, but I didn't know about this science because it was in the behavioral side of things. And me being in cardiovascular nursing, I was on the medical side of things, from the neck down versus, the neck up, as we refer to it as clinicians. So it felt really natural for me, and the outcomes were really good. So I started doing some research of the literature to find in behavioral health, that's where my investigation took me, to find some other interventions that encompassed the conversation between the clinician and the patient. And so I felt like, this is something that needs to be expounded upon for clinicians. Now, I remind you, this was 15 years ago and beyond that. So therein is where the National Society of Health Coaches, a colleague of mine and I, Colleen Miller, began to formulate and co-found this society to help train clinicians in a new way of engagement.
That's amazing. And I would imagine if you're watching this today, if you're a vestibular patient and you've ever experienced a doctor's visit or a therapy visit where you felt like they were doing all the talking, please chime in and let us know that, hey, I relate to that. When are they going to ask me about me? Because I think that the magic happens somehow when we shift the focus on what we need to tell you into what do you need to tell us. And so you found that worked and that it was something that could be taught. I know you brought with you a slide deck today. Is that something you want to go into right now where you might want to take us through a talk?
Into the first slide. I can tell you before you move on to the second slide is this title actually came to me from a colleague of mine who was taking the program at the time, but she also had a husband who was really having a difficult time with his cardiovascular disease. And she said to me, Melinda, when I finally got into the program, I realized what I had done and what I had done wrong with my own husband, because I had continued to tell him, as the nurse practitioner she said, I could tell him, you've got to do this, you've got to stay on this, you've got to exercise, you've got to take your medication. And she said, one day he looked at me and said, look, I know all about what to do. When are you going to ask me about me? And she said that was the turning point in our relationship in terms of me being the nurse and he being the patient. It changed everything for us. And then with the program, it filled in all of the necessary holes that I needed in order to converse in a very different way. And so let's talk about partnering. And that's the next slide, which you'll see a very different relationship begin to form. Heretofore, and even now, for clinicians who have not been trained in our health coach certification, you will see after that training, you begin to look at the patient very differently. You will see them as the true expert in their lives that they are. And they will be talking 50% of the time. And you will change from only telling because of the way we've been trained. Let's face it, the clinician has been trained. What all does the patient need to do in order to help be well, to promote recovery, to have a better life, to manage this condition? But it's all about telling. But there's a piece that we have always missed. And we've got to recognize that while we may bring the expertise to the relationship in terms of what to do clinically, it is that patient that holds the key as the expert in their own lives, because there is no patient that is the same. Yes, they may have the same diagnosis, but we're treating patients, not only the diagnosis. And I think the next slide will also depict this even a little better, because it involves behavior change. When you go in to see your clinician or your practitioner, your physician, there will be a host of things that they're asking you and that you're looking for in terms of, why am I here? Can you help me? Because you're obviously there for a reason and you can't do it without them. Well, change, it all will revolve around some type of behavior change. Even if it is just a medication, something as simple as a medication versus a whole entire treatment plan of meds, and exercise, and diet, and screenings, and diagnostics, and so forth. So let's just focus on the behavior change aspect of something as simple as a medication, which many times, if it's a new medication, there may be a lot of things that make it more complex than just a simple medication taken by mouth, maybe once a day. But we're looking at behavior change, and I like to think of it really like an iceberg. Look at the tip of the iceberg. There's 15% that's above the water, and there's 85% below. And I like to think of behavior change and our patients as, look, we've got to tap into that 85% below, because why? Think of the Titanic. That's what I like to akin this to. The captain of that ship, massive ship, saw a tip of an iceberg, but had no idea what was going to be before them in short order. So until it's that 85% that's very susceptible to currents and to flow. And so that I liken to behavior change, because there's so much that lies beneath the surface of what a clinician would see in a 15 or 20-minute physician's appointment that will make the difference in whether the treatment plan will be ascribed to, or whether the clinician will even see that patient as being part of what develops that treatment plan altogether. So, and the next slide will even depict this in terms of the patient even a little more clearly, because typically in a typical physician's visit or nurse practitioner visit, whoever prescribes your treatment for you, maybe even a physical therapist, the clinician, unless they engage you differently as a patient, will see about 15% of you, and that's with what they hear. They will ask questions in an assessment. They will do a physical assessment, ask a lot of questions, maybe do some diagnostics, maybe even review some diagnostics. But that's only about 15% of what's there. What the clinician doesn't see or hear lies below the surface. And what all is that? Well, I'll give you an example based on my own experience. I paid to go see a physician, took the time off of work to go see the physician, because it comes in steps, as you all know. I go to my appointment. I keep my appointment. He orders a medication. There wasn't a lot of, and this is like many years before health coaching. So for me, it's still going on now, but for me, it's not the same. And I'll go into that a lot later. But so I go to the drugstore, and now think about this. I'm taking the time to go to the drugstore, fill the prescription, get the prescription, bring it home. Think about the money and the time. But I decided based on some things that were of concern to me, the more I thought about that medication and me, I decided I'm not going to take this. I'm just not going to take this. Okay. I had my own reasons. Had we had a very different discussion about this medication in the physician's office, I could have saved him the time to have written a prescription, me the time to have gone and got the prescription. It wouldn't have taken that much time to discuss what was important to me about that medication, but that didn't happen. And so that's a perfect example of what is happening over and over and over in physician and nurse practitioner visits, or even physical therapy visits if they're providing an eval for you. I had that also happen in a PT visit for me. And as a physical therapist was giving me my treatment plan without really having discussed what I would or wouldn't do, what I thought I could do, or maybe why or why not, I was sitting there the whole time going, there's no way I'm going to be compliant with 2 of those exercises. I didn't say anything because I didn't feel comfortable saying anything. He was so busy telling me that I didn't feel comfortable in telling him my side of why, because I didn't really think he was that interested. But you know what happened? I didn't go back to that physical therapy.
Let me interject right there. if he had said probably one sentence or asked you one question, you might have felt comfortable disclosing your concerns. Because it does it narrow down to one question.
Absolutely.
What would that be? What would that be if you had heard one
that
thing?
Would be, why have what is the reason why you have ordered this particular medication in my case? And then I would follow it up with, because I would really be very interested in why he chose that medicine. And then let me tell you what concerns me about that.
So that's what you would say. I was thinking as I was listening to you, there's probably something the clinician could have said that would have given you a stage and an invitation to share that concern. And that question by the clinician would have been one thing. Only so of all the things they asked you to get to know what they thought was wrong with you, because we do know as diagnosticians that we listen to the patient and 85% of their diagnosis comes from their story. I mean, sometimes we use those kinds of numbers and we say, we know we have to listen, but then once we've processed and we've said, this is what you need, and then boom, we give you the treatment plan, you're saying they failed to ask one thing.
And the one thing that they failed to ask was, is there anything we've discussed today that concerns you in any way at all?
Mm-hmm. And that would have changed it for you. Well, good. I didn't mean to interrupt. I just was in my head. And from my training, because I took your training, it was those kinds of things of asking an open-ended question to give the client, the patient, the opportunity to say the things that we know are in your head. You know these things are in your head. Every one of you watching has had questions as they're telling you, this is the plan. You're going, well, wait, I've already tried that medication, or I've already done that, or maybe I'm afraid of this, or I haven't experienced this, or these things concern me. And that one question, is there anything about what I'm saying that concerns you, or do you have questions about? It's an open-ended question. It's not threatening, and it gives you an opportunity. So anyway, I love that.
Well, and there's another, and then I'm glad you mentioned that too, Kathleen, because there's another issue. And you brought it up kind of as a side, and that is the way that you go about emphasizing certain things. For instance, and now, do you have any other questions? Now, that is asked very hurriedly. It's not very interested personally. It's more like, this is the rote thing that I typically do with all my patients. Okay. Is there anything else? Do you have any questions? As you're kind of feel like you're scurried out, because you know their time is of essence. They usually spend 15 to 20 minutes with you max and then move on. So we are very task-oriented as clinicians. So patients are also put off by that somewhat as they go into an appointment. They already have that preconceived idea, and it's real for many clinicians. So
I will say a lot of patients who have seen a great physician or a specialist that has taken the time to sit down and listen will always make sure they come back and tell me or tell their friends or family, like, they actually listened to me. We were in there for like an hour and a half. And, you know, that makes a big difference with the patient's buy-in with their own care. That's one thing that, you know, we talk about and we advocate a lot for, especially with dealing with the vestibular patient population, is that if you sit and listen long enough, the patient will tell you exactly what is going on. And if you just kind of guide them along and ask little poking questions here and there, by the end of it, you're going to have a really good idea of what you can expect to see in your evaluation, what the patient might be able to tolerate as far as exercises and education is concerned. It's just so much more powerful to let the patient tell their story and then involve them in their plan of care, involve them in their treatment.
Absolutely. And that takes some training. And there is science behind all of that. And so that's what makes the training so helpful, is that it's all based on the conversation, how we are with patients, what we say, but more importantly, what we help them to say that will actually make a difference in whether behavior change can happen. Something else about this conversation is understanding why people don't change behavior. And this is true for all of us. And I love the study that was done by Susan Butterworth. At the time of this study, she was with Oregon Health and Science University, and it was a large survey. And this was, why don't people change behavior? She simply asked the question. And here is the top reasons why they don't change. Their values don't support it. Maybe they don't think the change is important. Maybe they don't think they can, which speaks of confidence. Maybe they haven't worked through their ambivalence about it. We'll talk about that more in a moment. Maybe they aren't ready, as in smoking cessation, let's say, when we work with patients. If they're just simply not ready, we know that occurs a lot. And there's things that you can do that we're not forcing them, but it makes us feel a little bit better about the relationship. Maybe they don't have a good plan. And when you think about this, how many patients, or all of us, let's say all of us, how many people today simply are just run ragged in their lives? They're moving from point to point to point with very little even rest in between. We've got insomnia, out the wazoo, and we wonder why we can't even cut off to go to sleep. So a good plan when it comes to health coaching in particular, and having that clinician that will talk to you and help you in different ways with conversation and include you in what that answer is really going to be for them. You can sort the plan out together, and it works. It forces the patient also. It gives them time away from their busy lives to have a plan, to look at, maybe 1, 2, 3 things that it's going to require to make this change, because a change is going to require them to think about that. They've got to consider what is really what is going to help me really make this happen. And they may not have adequate social support. They may have chronic conditions where the family is affected, or their close friends, or others that are involved in their daily lives, that it will affect them also. But I would like to spend just a moment on ambivalence. And this is, I love this image, because this really kind of shows what ambivalence is all about. It's it's conflicting feelings. There's a conflict in feelings. When a decision is difficult, we usually feel a couple of ways about it. I would maybe go to the gym more often, but I'm afraid those exercises may cause some disorientation for me. I would go to the gym, but for this. I would like to go out with my friends more, but what if the changes, or even travel? What if the scheduling kind of, and I end up maybe coming up with a migraine? So you see, it's the but in the middle, that little 3-letter word that is the cornerstone of ambivalence. I would do this, but for that. That's where people get stuck in the middle, and that prevents them from moving forward with any kind of change they want to make. And that is in where lies that 85%, where those are the kinds of things that typically don't get discussed, or maybe the patient doesn't feel comfortable in talking about that because of what we said earlier. Maybe they perceive that the clinician is in a hurry. Maybe they just don't feel comfortable talking about that because the clinician hasn't evoked that or drawn that out or asked. Now, really think about the concerns you have. If there's any, I want to know about those so we can work through that, because an ambivalence can completely derail a treatment plan at all. I mean, just
specific to the vestibular client, sometimes the person recovering from vestibular disorder is asked to do certain things that may provoke their symptoms. Exactly. And that is a pretty significant concern. And while the healthcare provider might know that that's true, sometimes we maybe could spend more time hearing the patient's ambivalence to following through with what we're asking them to do, because it's going to potentially make them feel bad. And that's a real acknowledgement. We know that, but every patient, when it's you in the office, your healthcare provider hopefully can let you express
exactly
that fear you have, and that concern of what time am I going to do these exercises? Am I going to be able to do my activities at home or at work or regarding my family or socially while I complete this exercise program at this frequency, for example, or if it's medications for migraines, or if it's dietary changes or stress management or sleep schedules. With any one of those changes, when we talk about changes here, we're talking about any change in your lifestyle or your health management at home that causes you to adapt the way your healthcare provider is asking you to do.
Absolutely, because that directly can affect the treatment plan, just like the things that you were mentioning. And that treatment plan, then you feel like you're managing it by yourself, but you really need to have your provider there, 50-50 partnership, to help work through that. And for that clinician to know, and practitioner to know the seriousness that you place on that. It's the social context of your life that it affects. And the social context of our lives determine our healthcare decisions. Yeah, think about that. Those healthcare decisions are made within the context of our lives. I'm not talking about the orders that a physician may give you for your treatment, but I'm talking about those orders and how it affects the social context will determine, just like it did for me. I don't think I'm going to go ahead and get that prescription. I've filled it, but I'm not going to take it. I've done some more research on it. Just not sure that I want to do that. So what did that leave me with? I didn't have anything else in my treatment plan. So it can affect all kinds of things in that respect. So true. Ambivalence, the but in the middle. So what I would love to do in the next few minutes is for you to really get a sense, all of us that are on the call today, is to get a real sense of what ambivalence feels like. So if you've got a piece of scratch paper or pen or pencil, I would love for you to think, and I want to give you a minute or two to really think about this, because it could actually make a difference in the life you're experiencing now. At the top of that piece of paper, if you would just simply write a behavior that you want to change, it could be any type of behavior. It could relate to a vestibular condition, or it could be something else. But just write that in at the top. Make 2 columns just like you see on the screen. And one, the left-hand column, is the reasons you stayed as is. Now think about the but in the middle. I would do this, but for that. And then on the right side, list the reasons you have for changing. And there may not be 3, there may be 1, there may be 4. But I want to give you a good 60 seconds to think about this exercise, and if you will, to participate in that exercise. So I'll be quiet for that period of time.
No matter who you are, we all have something we want to change. It's I can participate as well. It's universal.
Okay, I think that's given time. I'd love to hear from you all. Did you feel the ambivalence as you looked at the reasons for staying as is and the reasons you had for change? Many times you will see that there's about as many on one side of this equation as you do the other, and therein creates your being stuck.
Mm. Yeah.
Does anybody want to share what they may have determined from this exercise? I'd love to hear from everybody. Did you get a good sense of ambivalence?
I'll say from a clinician side of things, we definitely hear that a lot, especially on the second visit when patients come back after we've gone through and given them some home exercises. And I'll say, so how did your exercises go? Were you able to do them? Well, is usually how it starts. Or sometimes I would have loved to, but they make me really dizzy. And that's where we continue to educate and have this discussion where, yes, they might make you a little dizzy, but let's gauge that dizziness, because there's a good therapeutic level of dizzy with exercise. And then there's sometimes where it's too much. Like, let's piece that out and figure out how to make that work in your day, and then come up with strategies for people to put more reasons in those reasons to change column. It's very easy to get into that reasons for staying as is, but as long as we can keep lining up those reasons to change, I think that people start to be swayed over to, making that change gradually, but they need a little help, a little bit of coaching sometimes.
Sure. And it's true that with ambivalence, when you go through this exercise, I usually start all of my coaching sessions with this exercise, especially for new patients, because it also helps them determine exactly what their dilemma truly is. They may only think of it in terms of a symptom, but they may not actually have thought through all of these different things that affect their ambivalence about a certain issue. But the next step through this is to really look at both sides of that ambivalence and then determine what would be my greatest motivator for moving forward, because it's all about moving forward. When we're working with clinicians and patients together, it's all about moving forward in some way for some particular outcome. And I have found that many times patients, they actually haven't had, like we've said earlier, the time to think it through, but looked at it in this way. So a lot of times it helps them crystallize where they want to focus and where their greatest motivation can be for helping to move themselves to move forward. I had someone come in the other day, a 50-year-old female, hypertension, overweight. She couldn't put away the candy, unfortunately. And she came, as she walked through the door, she actually said to me, I know exactly what I need to do. And she wanted to come off of her hypertensive meds. She was on medication for high blood pressure. She wanted to come off of that very much. She said, I know what I need to do, but I have no motivation to do it. That, I think, is the case for most of us, depending on what it is that's preventing us from changing, no matter what that change is. So we really had to, after the ambivalence, this really helped to show her and me the different things that were affecting her ability to make that change. And then from there, you can look at having the patient describe, what do you think is the most important motivation? What of these reasons for change would help you to motivate yourself? What carries the greatest deal of motivation for you? And in this case, it was very interesting. She said, my husband feels like that I'm fine no matter. So she had never said that. She shared with me, she said, I've never really said that before or looked at it in that way. But he said that to me recently. And now I realize that really tempered my desire to go with this with gusto and to make a point to lose this weight no matter what, to get rid of the candy. All he had to say was, I love you no matter what you have going on. And she said, now I know that really tamped down my desire. So those kinds of things come out, but they can be revolutionary in someone's life. So just keep that in mind, that while this is a very simple exercise, sometimes it takes more than a minute, but to be respectful of our time today and to give those who are joining us today time to express themselves and talk about some of these things. I wanted to keep that short, but it can have tremendous effects in the end. So really, in a nutshell, a difference in the way that we used to do things and the way that many of us have taken to do things now in terms of our relationship with our patients. Health coaching does these things. We see ourselves more as facilitators and guides. We listen. Actively listening. There are skills to employ to help you learn to be a more effective listener, because there's cues that a patient may give you without even realizing it, that as clinicians we need to seize upon and not just let go out the window or go out, in one ear and out the other. We're going to be very empowering. Health coaching seeks to understand the issues that are of concern, like Kathleen mentioned earlier, by asking questions in certain ways and by reflecting and affirming certain things that we hear come from the patient, and based all on those patients' concerns that keep them from moving forward, versus the traditional approach of seeing the patient as someone we simply direct. And we do all the talking because we're telling you what to do. And we expect you to go away and do those things to yield a better outcome. It's more diagnosis driven, and it's according to our agenda and what we think you need to do. It's that 15% we see or hear of that iceberg only that prevents us from, in the past, and even now, many who have not gotten into a health coaching training or haven't looked at this approach as something that would be very revolutionary for their practice, you'll still see some of those traditional approaches going on. So
I was going to add to that. I love seeing the differences between the traditional authoritarian approach and the health coaching facilitatory approach. In my practice, it meant being able to encourage my patients to think about what they're willing to do. What are they willing to do to change? Or what are they willing to do in the program that I might put before them? And so, of course, being afraid of side effects of medications, or of course, being afraid of being dizzy when you do your exercises. These are fears that
very real.
Most people have. They're very real. And while we might not always look like we're acknowledging those fears, we do know that you come with those fears. So I want to empower vestibular warriors listening to this, that we do know that you have these concerns, and we do know that you want to avoid feeling your symptoms. I mean, who doesn't? That's normal behavior. So I encourage people to ask, or maybe you to offer to your healthcare provider, this is what I'm willing to do. I'm willing to try this medication for a certain amount of time, but if it makes me feel bad, maybe then I won't want to continue, or may I ask you again or call you back to talk about it, or tell your therapist, I'm willing to try these exercises, and then how about, could I touch base with you in a week, and follow up about it. So, I mean, I think those are ways that give you power as the patient. If your healthcare provider doesn't know how to empower you, you can take that power by knowing tell them what you're willing to do. Tell them what you need to feel comfortable, so that if you try something and it doesn't work for you, that you don't feel alone waiting for that next visit that might come, I don't know, 6 weeks from now or whatever.
Absolutely.
So,
I'll share if I may, a personal experience that I had with a physician several years ago when I was just first getting into health coaching, but I went to see a physician about an issue that I was having. And I went in, and a very busy gentleman, very, very busy. So I go in knowing this, but I also had some very specific concerns that I thought that he needed to hear in order to give me the kind of treatment plan that I could be compliant with. I thought this through. So I asked him, I was very serious about this because I knew from a previous visit what he was likely to order for me. So I said to him, I need you to partner with me in this decision. I want you to tell me about these things clinically that I'm not an expert in, but I also want you to hear the reasons I have concerns about this and why I'm not ready to just jump right in without knowing more from you and us working together on this problem that I have, this concern. It's really detrimental for me. And so we talked about this, and I said, okay, at the end of the visit, I said, I'm not quite ready yet to make that leap that you're wanting me to make, but I'd like to come back in a couple of weeks if you would be okay with that. And he said, absolutely. When I came back in 2 weeks, now remember, this guy, he was very, very popular. So he worked me in. But the most astounding thing to me was when I walked through the exam room door, sat down, and he came in after me. What he said to me was, hello, partner. I couldn't believe it. After all of the numbers, hundreds of patients that have come through his office during that time, he remembered that. Wow. People didn't ask him to partner. Nobody had ever asked him. He said, nobody had ever asked me that. I said, you call me partner? He said, yes, because you asked me to be, I want to try to fulfill that role for you. Because we did have, but like Kathleen said, I took the initiative, but look what it yielded me. And I don't want those of you on the call who are not clinicians to think that that was the difference, because you can do that too. When you share your concern about your treatment and about your condition, feel comfortable enough to say, look, I need a partner in this. I need a partner. I can't do this on my own, but listen to this, but there are things very important to me that I need to share with you about this. Do you see how that then begins to evolve into the treatment plan that together you will have? And remember this, the Institute of Medicine today is telling physicians that patient-centered care, which years and years ago was simply focus on the patient and their care needs. Well, that meant you were going to be a diagnosis walking through the door and out the door. We didn't even know what that meant. Patient-centered care, well, what really is that? The patient's always been the center, but we didn't do anything differently. The Institute of Medicine today says patient-centered care is having your care revolve around the values and preferences of the patient. That all, think about this, quote unquote, all clinical decisions are to be made around the patient's values and preferences. Now, remember, we just went through why people don't change behavior. Values, concerns, confidence level they have for it, the importance they place upon the change. All of those things comprise that 85% below the surface. But now know that physicians are being encouraged to engage you differently. So feel comfortable, a little more comfortable than maybe you have in the past, about kind of putting that toe in the water and getting out there in ways that I have described to you, that I believe that you will find very enriching in terms of the treatment plan that together maybe you can come up with along with your physician in that 50-50 partnership.
I think that's so helpful. I put in the chat even some things that we can encourage people to ask, and that I empower them to try to say, there are things I want to tell you that concern me, or
Yes.
may I respond and make sure I understand what you're asking me to do. May I tell you what makes me nervous about what I'm hearing, or what I'm afraid you're saying? And it sounds like from the chat that some people leave and the doctor tells them the plan, but the doctor hasn't yet told them what the diagnosis is. So I know that Danielle and I will be entering into an Ask the Expert video interviews coming up in the schedule, where we'll be talking about the challenge of getting a diagnosis for vestibular patients. That can be a particular challenge that is sad. It's not like you show up with chickenpox and we know it's chickenpox. When you show up to the doctor with a vestibular disorder, you may, leave there without knowing what's wrong. So even saying, what diagnosis are you arriving at? What are you thinking is going on with me? And what maybe has led you to suggest this specific treatment for me?
Right. Because as you enter an exam room or enter into a relationship with a physician, I mean, it's typically, what can I do for you? What seems to be the problem today? And then the typical visit is a physical assessment, asking questions, telling, and leaving with either diagnostic tests written to be ordered or prescriptions. That's very typical, prescriptions, and come back and see me in a month if you're still having issues. So I encourage you to think about these different things that you can interject into that conversation. And I love what Kathleen mentioned about ask permission. If you need to, may I ask you more about this? Or may I tell you what I think is going on? Or may I tell you what has been happening in lieu of that, or some other things that maybe they haven't inquired about? They would be hard pressed not to give you a little bit of time asking permission, of them, which I think is very, I like that, because it gives the patient a little more courage, if you will, to interject it in that way, as opposed to, look, I need a partner in this.
Right. Well, and so the doctor, so if your practitioner has not studied the communication styles taught in the certification course, and let me just be specific that what Melinda Huffman and her partner have created with the National Society of Health Coaches is these are for clinically licensed providers. This is a different sort of health coach than someone who is teaching you wellness or fitness or dietary coaching, but this is for licensed practitioners, whether they be physicians or nurses or physical therapists or occupational therapists. I mean, any licensed professional goes and gets this training and learns how to talk. And I want to encourage you to share this information with your healthcare provider until they know how to listen to you. Arm yourself with some of these introductory phrases that allow you to feel listened to. And another one I was going to say that really stands out and is applicable for this audience is, so you want me to go have these tests, you say, will that test change my treatment? Because I know a lot of people say, they wanted me to go to this test or that test, but in the end, my treatment strategy doesn't change. And sometimes tests are important to rule out other things. I agree with that. And the healthcare payment system has made sure that we're not over ordering certain diagnostic images and things. So we want to rule things out. But you'd be surprised how with a question, your doctor could defer an MRI, for example, and allow you to try a treatment before you go to further diagnostic testing. Would you agree with that, Danielle?
Yeah, and there's a lot in the chat in the comments from various platforms that we're streaming from right now that we hear and see a lot of. there are some times where patients go to see their doctors and their doctors maybe aren't comfortable or knowledgeable about the nitty gritty of vestibular dysfunction and starting to dive into finding out that diagnosis. And they almost feel passed off a little bit, which can be very frustrating to people and kind of give them that feeling that no one's listening. And I think that our vestibular patient population has done a really great job of being their own self-advocates. Find a clinician who does speak with this language, who does have the time to answer your questions and partner with you. I think it's really important that if you have a negative experience like that with a practitioner, that you need to go find somebody that will listen, that will specialize and find out what is going on with your symptoms and your, what's hindering your quality of life. Penny, I can see in the chat, it took her 16 and a half years to get a diagnosis. That is a long time. And there's Pamela in the comments too had mentioned that it wasn't until she got to a physical therapy appointment that she even knew what her doctor diagnosed her with. And that can be very frustrating because maybe you have questions about what the diagnosis is, what your prognosis is going to be like. And it can feel very defeating when you don't feel like you're a part of your care. So, listening to everything that we have to talk about today is absolutely amazing to empower our viewers and our listeners that are attending today as a patient. And for those of you that are clinicians, it's important to have this training because there are so many things that we can help patients with if we just listen. And sometimes we need those extra tools to figure out how to listen efficiently, effectively, and how to really help people that are seeking your needs and your help.
Absolutely.
And my personal experience is how empowering it was for me to step out of the authoritarian role of I'm supposed to know everything into, hey, let's work together on this. And I use words like, I have this toolbox full of different things we can do with you. And I don't really know. I know where I would start with you because it seems to work the best for people who present like you. But let's go through and do that together. And it actually takes some of the pressure off the doctors and the therapists and whatever from being perfect and from being right when we say, is it okay with you if we begin this way? And then we pay attention to how you're responding. And then maybe we'll change it up a little bit. And all of a sudden, you take away that distance between the practitioner and the patient. Yes. And I think that makes for not only a more successful plan that meets the patient's needs, but also the emotional part that we don't doubt plays a role in your recovery. Yes. And how you come to your exercises or how you come to taking in the medication. I believe strongly in my holistic practice that when you take a pill in your hand and before you take it, you need to be in a headspace and in a mindset that what you're taking is good for you, that what you're taking is going to help you, and that your body receives it willingly. And those are the kinds of things that I think increase efficacy 5, 10, maybe 15%. To be in that energy space of willingness to do, willingness to follow, and that your body would receive what it is supposed to receive out of whatever treatment is given to you.
And Kathleen, I think there would be so much more willingness on the part of patients if they felt their prescriber was in it with them, had that same concern for them. And while they may feel the concern, they've got to express that through a different kind of relationship. And patients know when they've been engaged. The satisfaction just shoots through the roof. There's just no question whatsoever in the satisfaction on both sides. But in choosing the right coach, we know that there's all kinds of coaches. There's health coaches, wellness coaches, life coaches. And so what are the difference? What am I looking for? If you have a clinical condition or you have a chronic condition of some kind, I would certainly look for a clinician health coach, because health coaching is not regulated today. It's still new, even though we've co-founded the society 15 years ago. It's still new in terms of coming on over to the medical side of things, but it's quickly getting momentum because of the kinds of things that patients are discovering, the kinds of things clinicians are discovering. So it's got a lot of legs underneath it, if you will, right now. But look for a clinician certified health coach. They're going to use clinical interventions and the skilled conversation to engage you and to treat you as that partner. Wellness coaching doesn't require a license. Health coaching, because it isn't regulated, doesn't require a license, but clinical practice is regulated through licensure. So that's why we highly recommend a clinician health coach. Wellness coaching, I would be concerned about someone guiding me, and I have a chronic condition that didn't have a clinical license to be, taking that condition, my condition, in consideration. But there are wellness coaches whose main goal is to help you maintain wellness, the patient already has a level of maintenance, and maybe it's not even a patient. It wouldn't be considered a patient. It would be considered an individual, just to maintain wellness. And then life coaching is more about greater fulfillment in life with career decisions, life satisfaction, how to establish more creativity, if you will. So that's kind of a basic difference in those three that might help you consider which one would do best for me, considering, what your needs are.
That's helpful. A lot of coaches out there trying to promote themselves. Make sure you get someone who has the training to handle you.
Yes.
We're going to go to questions and see what other questions are out there. And I'd like to ask you, those of you who are still with us in the chat, would you be interested in talking to a health coach trained in vestibular disorders? And do you think that would be helpful to you? I know at VITA, we look at ways to improve our support and encouragement to people. And health coaching is one of those things that we're thinking, does our audience have an interest in that? Is that something we could provide? Certainly, VITA exists to provide education and information and help you on your journey back to balance. Through our provider directory, you can put in your zip code or your country code and find someone who is practicing vestibular medicine in your area. We have a lot of information, whether it be on the website, on our Facebook, or on our other social media platforms. And we have written material that we can send you if you need it. We operate here for you. So in this changing climate of healthcare, we think it's important to educate you about the different kinds of coaches out there and the fact that a health coaching education is something that your clinicians may experience.
I have a quick question. I've looked into this. This is something that I'm actively hoping to pursue here in the near future. Can you just give me a brief rundown of what the certification process looks like for a clinician? What's involved, what's expected of the program?
In our program, it's contained as a guided self-study, which makes it very convenient for you. You start on your own time. You end on your own time. It's a blended study. So you will be taken through a whole process of different skills that you will begin to practice. We have live practice that is highly, highly popular. I can say without any hesitation, you will love it because it's very safe in terms of how we go about this group practice. You learn from each other as you critique each other, actually in coaching me, in coaching others. So you will go through this entire program. It only takes 85 to 100 hours, although we give you a whole year to complete your program because people are very busy with their working lives full-time, their families, other responsibilities that they have. And sometimes life gets in the way and someone has to put off their study, but you can stop and start at any time. So you make it as convenient as possible for you. And then there is a very rigorous 125 item certification exam and multiple choice, and then also a skills competency.
That sounds really intense and awesome at the same time.
In order to bestow certification.
You guys do some great things. I was looking for it because I keep it here next to my desk. I took my training, I don't know how long ago, but you still gave me this little flip chart, this little, cue card. a pocket guide, which is so helpful.
Good.
So,
It's
I mean,
used in the field. Yes, we still have that pocket guide, by the way.
I like the pocket guide. It helps me remember, and just keeping in the forefront of my mind that my goal is to partner with clients. And when I do that, they are more satisfied and they feel better. And there's so much just about feeling like you're partnering with someone. I go back to the idea that research supports this idea that quality of life improvements do not depend on remediation of all symptoms. And so when a person feels like they're partnering with their healthcare provider, they instantly have an improved quality of life that comes even before their symptoms have diminished. And I think that's what we're after, is people feeling better and functioning better, even though they might be having some chronic symptoms.
Yeah.
So that was a mouthful of things. I hope that made sense, but that's the deal. That's improved quality of life with or without dizziness. Well, what else, Danielle?
I was just going to say, you were very generous with Vita in allowing our professional members to get $100 off for a discount on a certification program through the National Society of Health Coaches. So if you're a professional and you're interested, if you are already a pro member of Vita, if not, you should join and become a pro member of Vita. When you join, there will be a access code in the professional forum. So you can get onto our website at vestibular.org and go to the professional forum and find our code there for our pro members. I just want to also pitch out there for any clinicians who are watching and using our resources and utilizing all the stuff that we bring to the table for our vestibular patients. Pro membership is greatly important to Vita in helping us do the things that we want to do for our patient population and our pro members. There are a lot of benefits and value added to our pro membership, and it's only going to get better as we go down the road with some things that we've got planned and coming up in the pipeline. So be sure to sign up if you're not already a member. You'll have lots of great newsletters that include information like offered courses, pro member forums where you can discuss cases between other clinicians, so much more. So make sure you check that out at vestibular.org, and you'll see a link there for our healthcare professionals. Also, be sure to check out the discount code that we have for that $100 off of the certification if you are interested. And Kathleen, am I missing anything?
No, I think you got it. Melinda, we are just so grateful that you would take time to be with us today. I'm going to take a minute to show your promotional video for the Health Coaching Academy or a course, and then that will be followed with our regular outro. So again, thank you so much for being with us. And I know that those who have watched have left with some nuggets of good wisdom. Thank you for empowering us.
So thank you so much for inviting me. You all are wonderful. I love Vita, and I really do appreciate your having invited me to be a part of today. Thank you.
Absolutely. Take care.
As many as 50 to 60% of patients don't follow their treatment plans or take medications as prescribed, costing more than $1 billion a year in the U.S. Don't risk patient resistance and noncompliance. Learn new conversational skills and strategies that tap into the patient's client's own motivation to change health behavior. Don't delay in learning how to effectively engage your patient client as a 50-50 partner in health to achieve optimal health and wellness, lowered health risk, and decreased healthcare costs. The National Society of Health Coaches, NSHC, Education, Training, and Certification Program, evidence-based health coaching for healthcare providers, is based on a practitioner's existing clinical knowledge, skills, and expertise, developed by clinicians for clinicians. Study according to your own busy schedule. No classroom requirements. 97% of users recommend our program. Best in content, most readily applicable. Contact us today.
Go to vestibular.org for more videos like this one. Also there, you'll find information, support, and encouragement to help you find your journey back to balance.